Welcome to Vein Lymphatic University. My name is Lola Kadnick, and this is our Grand Rounds. We're broadcasting on Zoom as well as YouTube. Dr. Kanata, who is in the background, is helping us with the Zoom platform. And I'm going to turn this right over to our speakers and our discussants. Today we have Professor Davis from the UK, who's going to be our lead speaker, and discussants Ayman Fakhri from Egypt and Shoaib Padira from India. So, Alan, the floor is yours, and thank you very much.
Well, thank you very much and for this opportunity to talk to the VLU. And I want to talk to you about what we should do with respect to prophylaxis for people who are having endovenous ablation of a truncal vein. Now, I all want you to think about, and the important thing is that you should always think about the risk of VTE 100% of the time that you are offering an intervention to your patients. You may call it sensational, but this is headlines from an Irish newspaper, from a UK newspaper, of young women who've died following simple varicose vein surgery. And I can assure you, in these two cases in the UK, the surgeons and the hospital ended up forking out a lot of money. We know that superficial venous disease is associated with an inflammatory process, and that any inflammatory process is associated in the body with an increased risk of VTE. We certainly wrote previously that there is no good level 1 evidence what you should do. We need an RCT. There's no good evidence about efficacy, what is cost effective, and how does it affect people's quality of life. If we look at the various assessments there, you will know about the Caprini scoring system, which actually has varicose veins down as actually being one of their risk factors. If you look at the incidence and association of venous thromboembolism, peripheral arterial disease, that actually varicose veins are associated with VTE with a health-related issue of about 5.3. So if you take that all into account, the other important thing is hospital-acquired thromboses that actually occur with a significant number of admissions. If we look at the data, because we're now doing everything in an office under local anesthetic, even so, the reported VTE risk is around about 3.4%, and this is comparable with data for people who are undergoing major hip or knee interventions. If we look again at the scoring systems, you can see very clearly here that the UK Department of Health actually puts varicose veins, but with phlebitis as being a risk factor. If we then look at the data from the Caprini scores I mentioned previously, it's slightly different. It's just the mere presence of varicose veins. And you can see very clearly that the ESVS recommendations are such that it's something that you should consider doing a risk assessment, and that we should be personalizing the risk assessment of people who are having varicose vein interventions. So what is global practice? Well, we actually reviewed all of the global guidelines from America, Europe, and other parts of the world. And we applied, as many of you will have heard me talk about, the Agree-To tool, which looks at various domains to actually look at the quality of the recommendations. And it is quite clear that the recommendations with respect to pharmacological prophylaxis at the time of superficial endovenous intervention are completely and utterly inconsistent. They're completely ambiguous, and they're based on very low quality evidence. So in very simple terms, nobody has got a clue what we should be doing, and we need some high quality research to make some decisions. Now, what actually happens in the UK? Well, actually in the UK, on 2 surveys that were done not that long ago, but in the last 6 years, you can see that one study showed that at least 52% of people were getting a single shot of low molecular weight heparin, whereas another one showed that 71% of patients were getting a single shot of low molecular weight heparin. And there were even some patients who are having treatment up to 28 days. So we recently repeated the survey, and I'd like you to look at this, that there's basically, over the last 5 or 6 years, there has actually been no change, and 67% of people routinely give a prescription of low molecular weight heparin. So there is obviously an issue that we need some level A evidence. So we also did a global survey, and this global survey showed that there was significant variation in practice. It was occasionally what people deemed it was driven by what the patient's risks were, but everybody was in agreement that there was no validated assessment tool. And I'm just about to show you a horrible slide, and you'll wonder why I've shown it, but you'll see, I hope, that we actually divided these people in the survey to those who routinely assessed and gave something, of those people who made no assessment at all of VTE risk. And you will see the color coordination that I've put there. And I want you to just look at the blue and the green. The blue shows quite clearly where there is no prophylaxis, and those where there is a single shot used. So all I want you to do from this, and you can read the paper to get it in detail, but you can see that there is a complete lack of uniformity as to what people are actually doing, and that may in itself be a significant risk. So what should we do? Well, we have done various studies in the past, and we've also raised the question, does actually compression prevent VTE at the time of prophylaxis? Well, the answer is we don't know. But there is one website, just for an example. This is taken from a very esteemed colleague's website, who said that one of the most important reasons for wearing your compression is to prevent the risk of DVT. Now, how many of you believe that or not, when most of the guidelines now recommend you should only wear them for a week at most, and some, including NICE, recommend only 3 days. So we did a paper to look at what is actually going on with respect to the benefits of wearing compression alone, compression and some form of anticoagulation, be it low molecular weight heparin, or be it prolonged prophylaxis for anything up to 28 days. And you can see very clearly here that if you just use stockings alone, you are running a VTE risk of around about 2.26. And as you know, I said that and highlighted a figure of 3% previously. But if you use anticoagulation and compression, you may be able to get that down to 0.5%. As there's obviously this discrepancy, the UK government through the NIHR raised this as a significant question as to what we ought to be doing, and it was identified as being a heterogeneous practice. So this led us to go on and get something called the Thrive trial funded. This was a commissioned call, and the government have given us £2.5 million to try and answer the question. And you will recognize some of these people who are vascular surgeons, methodologists, who are all part of the team that are trying to answer this question. And the trial is very simple. It's all patients undergoing endovenous ablation of a truncal vein, get randomized to either compression alone, compression and single shot of low molecular weight heparin, or compression, single shot of low molecular weight heparin, and an extended course of low molecular weight heparin and DOAC up to 14 days. And the primary outcome is VTE at 90 days. So to summarize, we would certainly all agree that mobility is important in these patients. We're certainly not going to use intermittent pneumatic compression devices. Stockings are probably of no benefit in prevention of VTE in this cohort. Chemoprophylaxis certainly does seem to be our best benefit with respect to prophylaxis. I fully accept we don't know whether there is a specific high or low risk because there are no good assessment tools. And the key thing probably to take home from this is that you should be clinically aware and make sure that you make some assessment of your patient. I think it's very important that we don't know the answers, and this is a particular reason why we should be doing more research in this area. And thank you very much for listening.
Thank you very much, Professor Davis. I have a question for you right off the bat. What is your practice?
My practice is that everybody goes into the Thrive trial. Prior to the Thrive trial, everybody would get a single shot of low molecular weight heparin.
Now, in the UK, do you see your patients post-operatively if there's no complaints?
The NHS standard treatment is that patients have their procedure and are discharged back to their GP.
Okay, thank you very much. Professor Fakhri, the floor is yours. If you want to share your screen and your slides.
Thank you. Thank you very much for a great opportunity joining this great university, and it's my honor to have the chance to comment after Professor Davies. Let me start my comment by this, our big question. Is anyone immune to develop VTE in superficial venous community? The answer is no. Let us claim that 1 + 1 + 1 does not equal 3. VTE risk in superficial venous thrombosis, we have multi-factors. We have varicose veins, and the incidence of VTE finding in the retrospective cohort study in Taiwan revealed that in more than 425,000 adults, the presence of varicose veins was associated with high significance of increased incidence of VTE. Number 2, patient risk factors. We have low VTE risk patient and high risk patient. This is the individual risk factors and the procedure-related risk factors. This 1 and +1 + 1, this does not give the sum of 3. No, it gives you the sum of 5, 6, or more. This is multifactorial that aid a lot to develop VTE in varicose vein patients. We reported that VTE rates up to 3.4% of in varicose vein patients. This is very nice paper. The thromboprophylaxis strategies in patient undergoing thermal ablation in UK. As Professor Davies showed us, this great paper and demonstrated that evidence is required to establish whether patients undergo endovenous intervention benefits from pharmacological thromboprophylaxis. That's why, what's the optimal thromboprophylaxis following superficial endovenous treatment? What is it? No level 1 evidence. RCT is needed, highly needed. That pushes us to publish our paper last year with Professor Caprini, published in the Journal of Angiology and Vascular Surgery, validation of Caprini's softness ablation score. This study was done in Alexandria, Egypt, in about 60 patients, randomized in 3 groups. Group 1 treated with prophylaxis according to standard Caprini score. Group B treated with ablation according to modified Caprini varicose vein score, and the third group treated without any prophylaxis. This is the modified Caprini score for varicose veins. As you see, it is age and history related. 1 group for 8 points, and 2 group for the procedure history. Again, it's about 8 points. We calculate the score, and according to this score, this is the risk: low, moderate, and high. This is according to the Caprini and the modified Caprini score. And we did our prophylaxis according to this score. And we reached the conclusion: risk assessment patients undergoing varicose vein ablation done by applying Caprini's softness score as a better alternative to standard Caprini score for VTE prophylaxis, and is considered a safe and cost-effective tool in venous thromboembolism prevention in these patients. Thank you.
Thank you very much, Professor Fakhri. I do have a question. Do you have a question to Professor Davis?
Yes. As Professor Davis showed, in his practice, he gives his patients one single shot of low molecular weight heparin, and that's all, regardless of the risk assessment, and that's all. I would like to ask about the instance of VTE with his patients, and did this prophylactic measure of one single shot uh, uh, changes the way of breaks or down estimate the risk of VTE?
The straightforward answer is, just for absolute clarity, the standard patients used to get a single shot of low molecular weight heparin. If they were individuals who'd previously had a deep vein thrombosis, a superficial vein thrombosis, and were by definition obese, that cohort of patients would get a prolonged DOAC anticoagulation, but that is not based on any good evidence, but that's what we would do. So we were relying on a clinical assessment of the patient, and having had many conversations with Joe Caprini about that in the past, I think what happens is that people actually do often forget to assess the patient because some of these things are relatively obvious.
Thank you very much, Alan. I'm going to turn the floor over to Professor Padiria, and he's going to comment or ask you a question.
So thank you very much, Professor Davis. I think this was an excellent presentation. Very important points raised in your presentation. We all know, of course, that VT is occurs in a significant number of people across the board, whether low risk or high risk, you really cannot predict. Having said that, we also know that EHIT, even 1 and 2, do progress over a period of time, up to 7 days, sometimes 14 days. So VTA can also occur in the longer duration after the procedure. While it has been said that you must do a scan at 1 day, 3 days, and 7 days, practically in most of the world, that is not possible. The patients are treated and let go. And therefore, I think it's very logical that we give some anticoagulation to the patients, irrespective of the fact whether they're low risk or high risk. You have said that you were giving low molecular heparin a single shot. We used to do that earlier, but then realized that the efficacy of low molecular weight heparin doesn't last as long as a week. And therefore, over the last year or so, we've started giving a rivaroxaban, 10 milligrams daily, once a day, for a period of 7 days. And if the patient is high risk, then increase rivaroxaban at 10 milligrams once a day up to 2 weeks. Now, this is purely empirical. There is no data for this, but there are a couple of papers, one of them published earlier this year from Mexico by Gonzalez, in which he showed that the incidence of VTE in the patients given rivaroxaban compared to those who were not given rivaroxaban was statistically different, significantly better. So I think there's a point there. As far as the THRIVE trial is concerned, 2 things. One is, which low molecular weight heparin are you going to use as a single shot? Secondly, which oral anticoagulant you are going to use? And when you say prolonged anticoagulation, what do you mean by prolonged anticoagulation? What is the duration?
Okay. Well, as you'll know, I'm a pragmatist. So, and this is being conducted in 42 different hospital sites. And the straightforward answer is the choice of low molecular weight heparin is left to the individual institution. The answer is, with respect to the DOAC, it is either rivaroxaban or apixaban at their prophylactic dosage regimen, and that can either be 7, 10, or 14 days. So there are degrees of pragmatism in there that you can criticize. I think the one thing that we haven't mentioned, and all of this work may go into smoke is that there are now these DOACs that have a half-life of 7 to 10 days that you just may be able to pop one pill. And I am beginning to think that we may want to think about looking at that. The only drawback is that there has been some evidence to suggest that in the AF population, they don't work. But I think we should all be watching this space.
So if I may take this further, when you say the prolonged anticoagulation for 1 week, 2 weeks, or 3 weeks, do you categorize patients as far as the risk profiles are concerned and then decide how long to give the anticoagulation for?
In the trial, it's obviously completely random.
Then how will we come to a conclusion?
Because the answer is there's no evidence that 7, 10, or 14 days, any of those are any better. The straightforward answer is that I would hope that most advice from most guidelines is that you want to cover patients until they are fully mobile. Now, I also know that there'll be people here who will say, well, look, we've done an endovenous ablation. The patients are fully mobile. Well, I accept some people are if you're doing very cosmetic veins, but if you are dealing with very large, troublesome veins, most people are not actually fully mobile and back to normal within 24 hours.
And what sort of compression are you suggesting for these patients when you say the roof with compression?
Shoaib, I'm going to butt in here for a moment because we're talking almost nationality and how things are done in each country. And I haven't weighed in the US and what's going on here, but typically for superficial venous disease, there may be some assessment, but the criteria, as been mentioned, is pretty spotty in terms of risk assessment and validity. So that's where we're at. Do we routinely prophylax in the United States? No, I don't, and the majority of us do not. As you mentioned that in terms of EHIT, that the progression of EHIT over 7 to 10 days is very limited. And there's been a study to show that it's very limited. The fact is that we follow our patients within 72 hours to 1 week. And the question is, do you treat that EHIT? Now I'm talking thermal ablation. I'm not talking anything about glue. I'm not talking anything about foam. So typically we do not standardly prophylax. There's a question, Alan, to you from one of our listeners. What dose of low molecular weight heparin are you using?
Depending on the brand of low molecular weight heparin, we are using the recommended for weight and renal function, the appropriate dose for prophylaxis. We are not giving a therapeutic dosage.
Then there's a question from Dr. Khanna. If one injection is to be used, then what will be the dose, which we answered, and what time does it have to be given?
The answer is nobody's got a clue. But what we do is as the bandages and the compression is going on the legs, the low molecular weight heparin gets given.
So it's kind of interesting because when we used to use prophylaxis, it was done typically before the procedure.
Well, Lola, I think that's a very interesting thing because my understanding, and I will be corrected, and I'm not talking about venous surgery, my understanding that in the US, when we were talking about more surgical interventions, people tended to start the low molecular weight heparin later than we did in Europe. But I may have got that the wrong way around. But I think if you look at it, that
at least in my practice and most practices where I worked at, we started at the time of surgery.
Right. Okay.
It's interesting if you give it post-surgery. I think there's been some data to show that it may not be effective.
Yeah, because there were certainly papers that did come from the States where people used to withhold it for 24 hours. But anyway, that's not relevant to this conversation.
No, I'm sorry, Shoaib, your next question.
No, it's not a question. It's just a comment taking this further that this point that you raised about the prophylaxis timing. So we give low molecular heparin about, if we are giving low LMWH, we give it 4 hours before the procedure. And if it's oral anticoagulation, then I'll give it the night before the procedure. It doesn't increase the risk of bleeding or any complications, one single dose.
I don't know many people now who stop people's anticoagulation before they do endothermal ablation or simple avulsions. If I have got, I accept, if I've got somebody who has got masses and masses of phlebectomies, I do occasionally bridge them because I know that they are going to bruise plus. But most people, I think, would now be just treated on their anticoagulants. And I think what is interesting is some interesting information that I can share from the Thrive study is the number of patients. Around about 25% of the patients we approach are already on anticoagulation prior to having their veins treated.
So one very interesting observation from the last 1 year after we started doing this oral anticoagulation, we always use thermal ablation along with some degree of foam sclerotherapy in the below knee veins. And a significant number, I don't know percentage, would complain of pedal edema, ankle edema after the procedure for some period of time. And they will also have some discomfort in their calf and around the ankle after the procedure, probably because of the foam sclerosant which was used. Once we started using the anticoagulation, somehow that discomfort in the calf and ankle has disappeared, and the amount of patients we see, number of patients we see with ankle edema has decreased significantly. So I don't know whether originally this was because of low level of DVT, which we were not picking up earlier on ultrasound, and this is preventing the oral anticoagulation is preventing that. I'm not sure of that.
I'm going to jump in here, and I think that's an interesting observation. And I think you need to look at that because if we look at foam sclerotherapy and we look at DVT rate or thrombus extension, it's really debatable about what you're doing at this point. So I think it's a good thing to look at. It's something in the future. It's a really good thing, Alan, that your group and everybody else is contributing to this because obviously there's no directive here. There is directive, but there's no real good evidence. And so I don't believe that what you're doing, what I'm doing, or what Shoaib or Eamon are doing necessarily is the right way of doing it. So hopefully you'll come up with the answer. And how long do you think the study is going to be?
I think we'd probably have an answer in around about 18 months by the time it goes through all of the statistical and everything else review is the straightforward answer. But I think that seeing the time, I think the biggest take-home message, irrespective of the trial, is just for people, think VTE if you're doing endovenous ablation. You might not need to do anything, but you should always just think about it. And certainly, obviously, consent the patients for it.
Well, that's kind of interesting. I think whenever we're doing a procedure in surgery, we need to think about VTE or even in the hospital, et cetera. And so I want to thank everybody here, especially Alun Davies for the wonderful presentation, Shoaib for your interesting comments, and Eamon as well. And next week, we are going to be looking at in C6 patients with superficial venous perforated reflux and deep venous obstruction, superficial venous system should be treated first. And as you can see, it's going to be pros and cons and discussants. The interesting part of this will be our first grand rounds that'll be in Spanish only. It'll be led by Jorge Ulloa. And so we look forward to next week, our Spanish colleagues, 9/24/2025 at 12 p.m. And thank you very much for joining us.